So now we'll be starting the neurodevelopment. So the notochord induces overlying ectoderm to differentiate into the neuroectoderm and now forms the neural plate. Neural plate gives rise to the neural tube and neural crest cells. Notochord becomes the nucleus pulposus of intervertebral disc in adults. Adults are sensory regulated by TGF-beta, including bone morphology, protein, BMP. Basal plate ventral motor regulated by sonic aggregator SSS, or same orientation as the spinal cord. So the telencephalon is the first part, diencephalon is the second part, and then rest are arranged alphabetically: mesencephalon, metencephalon, and myelencephalon. Okay, so the forebrain prosencephalon gives the telencephalon, which forms the cerebral hemisphere and lateral ventricle. Diencephalon gives the two die, thalamus and hypothalamus and retina, and third ventricle, whereas the mesencephalon gives the midbrain and the cerebral aqueduct, whereas the metencephalon gives rise to the pons. This part, mesencephalon is a midbrain, whereas the metencephalon, hindbrain, is also known as rhombencephalon, and rhombencephalon gives the metencephalon and myelencephalon. So metencephalon forms the pons and cerebellum, is the upper part of the fourth ventricle, whereas myelencephalon forms the medulla and lower part of fourth ventricle. So central and peripheral nervous system origin: neuroepithelial in the neural tube, CNS neuron and CNS glial cells, astrocytes and oligodendrocytes and ependymal cells. So neural crest cells forms the PNS neurons, dorsal root ganglia, autonomic ganglia, parasympathetic ganglia, PNS ganglia, the swamp cells, the stellate cells, adar medulla, melanocytes, face brachial arch mesenchyme, mesoderm are microglia like macrophages. So in the cases of neural tube, neural pores fails to fuse at the 4 week of development. Persistent connection between the amniotic cavity and spinal canal, as with the diabetes and folate deficiency during pregnancy. Increase alpha-fetoprotein AB in amniotic fluid and serum, except spina bifida occulta, where is normally FP. Increase acetylcholinesterase in amniotic fluid is helped confirmatory. Spina bifida occulta, meningocele is meninges herniated through the bony defect, but no neural tissue. Meningomyelocele is meninges and neural tissue herniation through bony defect. Myeloscasis is also known as rachis, exposed confused neural tissue without skin, meningeal covering. Anencephaly is failure of the rostral neuropole to close, no forebrain, open calvarium, finding include polyhydramnios, no swelling center in the brain. Holoprosencephaly, developmental field defect characterized by the failure of embryonic forebrain prosencephalon to separate into the two cerebral hemisphere, occurs during the 3 to 4 week development, may be related to mutation in the sonic aggregator pathway. As with the other midline defects include the cleft lip or palate, encycloplasia, increased of pituitary dysfunction like diabetes insipidus, Messi with Patau syndrome, trisomy 13, and maternal alcohol use. MRI reveals monoventricles and fusions of basal ganglia. So lesioncephaly is failure of the neural migration resulting in the smooth brain that lacks sulci and gyri, may be associated with the microcephaly, ventriculomegaly, and hydrocephalus. So next with the cherry malformation, which is associated with the syringomelia and the tonsil herniation. Cherry 2 malformation with the two structures, the burnish and the tonsil herniation. So it is doing the non-hydrocephalus again. So the cherry 1 malformation is with the headache and the cerebral symptoms. Okay. So cherry 2 is associated with the what we call the myelingomelanism. That is because the paralysis and sensory loss at and below the level of the lesion. Okay, so this cherry more severe than cherry 1. Cherry 2 is more severe and usually presents early in life. Tenniwak is a disease of cerebral burnish. Cystic enlargement of the fourth ventricle, finishes the enlarged posterior as with the non-coordinating hydrocephalus. We have the syringomelia, which is a cystic cavity within the central canal of the spinal cord. Fibers crossing in anterior white commission spinal thalamic tract are typically damaged first, results in cap-like bilateral symmetrical loss of pain and temperature. Since in the upper extremity, fine touch is preserved. So with the cherry 1 malformation, and shows lower lying cerebral tonsils, scoliosis, and congenital malformation, acquired cause trauma and the tumors. Trauma and tumors can cause syringomelia. Most common location is cervical, then thoracic, then the lumbar. Okay. So basically the main thing is bilateral symmetrical loss of pain and temperature in a cap-like fashion. Okay, in the upper extremity. So in upper extremity, bilateral symmetrical loss of pain and temperature, whereas the fine touch is preserved in the upper extremity. Okay, that is syringomelia. So while talking about the taste sensation, okay, the first pharyngeal arch forms the anterior 2/3 of the tongue sensation by sensation. Okay, by V3 and taste by V7. So the posterior in both taste and tongue is by 9th arm, okay, and that is from the third and fourth arch. Again, first arch is the anterior tongue, second, third and fourth arch from the posterior 1/3 of the tongue, sensation and taste mainly by 9th arm, exterior posterior by 10. Motor innervation by 12th to hypoglossal to tracts and depresses the tongue. Then glucid protrudes the tongue with a styloglossus to the side of the tongue upward to create a trough of shallow. Motor innervation by 10th to platoglossus elevates posterior tongue during swallowing. So the neurons, signal transmitting cells of the neuron, permanent cells do not divide in adulthood. Peremptory relay cells with dendrites, cell bodies and axons. Cell bodies and dendrites are seen on the initial stem RER. RER is not present in the axon. Neurons make neurofilaments, proteins, synaptophysians. Astrocytes are most glial cells in the CNS. Physical support repair of excess neurotransmitter, component of blood-brain barrier, glycogen full resolve. Okay, and reactive glycolysis in response to neural injury, right from the neuroectoderm, astrocytes, ZFAP. Microglia is a phagocyte sensor of the CNS, activates in response to tissue damage, release inflammatory mediators like nitric oxide, glutamate, not really distributed by discernible by initial strain, derived from mesoderm. HIV infected microglia fused to form multinuclear giant cells in CNS and seen in the HIV-associated dementia. Next, we have the ependymal cells, ciliated sepal columnar glial cells lining the ventricles and central canal of the spinal cord. Apical surfaces are covered with the cilia. Okay, and microglia which helps to prevent the CNS absorption derived from neuroectoderm. Specialized ependymal cells, overhead patches of produces the CSF. Next, we have the myelin, which is increased conduction velocity of the signal transmitted down axons. Sartorial noda cranberry. Okay, so CNS oligodendrocytes, PNS is Schwann cells. The mnemonic is COPS. So myelin wraps and insulates axons. Myelin decreases membrane capacitance, increases membrane resistance, and increases space length constant and decreases the time constant. Very, very high yield. Myelin wraps and insulates the axon, decrease membrane capacitance, increase membrane resistance, increase space length constant, and decreases time constant. Okay, so Schwann cells promote axon regeneration derived from neural crest. Okay, injured in Guillain-Barré syndrome and Schwann cells marker has 100. Okay, oligodendrocytes is myelinate axons of neurons in CNS. Each oligodendrocyte can myelinate many axons. Primary type of glial cells in white pattern. So derived from neuroectoderm, fried eggs, appearance histology, injured in multiple sclerosis, progressive multiple leukodystrophy. Okay, oligodendrocytes are damaged in MS and progressive multifocal leukodystrophy in brain. Okay, now we'll be talking about the resting membrane potential. Membrane is resting membrane. One is more permeable to potassium than sodium at rest. Voltage gated sodium channels are closed. Membrane depolarization, sodium activates tap and sodium influx inward. Okay, membrane depolarized and sodium inactivates gap in the peak and thus stopping the sodium inflow. Potassium activates gate opening channel, potassium outward. So for the membrane depolarization, sodium flow is inward. For the membrane repolarization, potassium flow outward. सोडियम चाहिँ भित्र जान्छ, डिपोलाइज गरिदिन्छ, फेरि रिपोलराइज गरेर पोटासियम बाहिर गरिदिन्छ. मेम्ब्रेन हाइपरपोलराइजेसन, पोटासियम एक्टिवेट्स गेट स्लो टु क्लोज, एक्सेसिभ पोटासियम इफ्लक्स एन्ड ब्रिफ पिरियड अफ हाइपरपोलराइजेसन. So what happens is membrane hyperpolarization is a step. Okay, so during this condition, the excess membrane hyperpolarization, potassium activates gates are slow to close, so excessive potassium efflux outward and brief period of hyperpolarization. Solder gate border channel switch back to resting state. Sodium potassium pumps restores the ionic potential. So now next we have the free nerve endings. The 8 delta fibers are the fast myelinated fibers. C fibers are slow unmyelinated fibers. Present due to the pain and temperature. All tissue except cartilage, eye, lens, and numerous in the skin. Next we have Meissner's corpuscle, which is for large myelinated fibers. Okay, so they are present in the hairless skin. Okay, and that is called glabrous skin. And Meissner's means me lightly touch garai malai dynamic suma हैन. अनि लो फ्रिक्वेन्सी भाइब्रेसन देऊ आफ्नो हातले हैन, अनि पोजिसनलाई सेन्स गरेर मेरो कहाँ छ हैन, अनि लो फ्रिक्वेन्सी भाइब्रेसन र स्किन इन्डेन्टेसन. ओके, so similarly now we have the low frequency vibration, so we must have the high frequency vibration. So high frequency vibration भनेको कहाँ छ भन्दाखेरि high frequency vibration and pressure are present in the Pacific Ocean. So Pacific corpuscle, so that is the deep layer skin and ligaments and joints मा हुन्छ हैन. Large myelinated fibers adapt quickly. Next we have the Merkel. So that is the fingertip. Merkel भनेको कसैलाई मार्नु भनेको आफ्नो फिङ्गरटिपलाई हानी मार्ने हो कि फिङ्गरटिप एन्ड सुपरफिशियल द स्किन. सो द्याट इज डुइङ सम दि प्रेसर एन्ड डिप स्ट्याटिक टच. डिप गरेर मात्रै मार्न सकिन्छ नि त, मर्केललाई मार्नै पऱ्यो हातले गरेर होइन. लार्ज माइटेड फाइबर्स एडप्ट स्लोली. रफेनिङ इज like joints, okay. So like the fingertip and the joints, stretch joints, angle chains, okay. So angle chains गऱ्यो भने फिङ्गरटिपमा पनि हुन्छ, तर जोइन्टमा स्ट्रेच एङ्गल चेन्जहरू हुन्छ. लार्ज माइटेड फाइबर्स interweaved among collagen bundle fibers adapt slowly, okay. So the next we have the peripheral nerves, okay. So we have the endoneurium that supports the individual myelinated nerve fibers may be affected in the Guillain-Barré syndrome. We have perineural, that is blood nerve permeability barrier surround the fascia of nerve fiber, okay. Epineurium is dense connective tissue that surrounds the entire nerve, fascicles and blood vessels. So epineurium is like dense connective tissue that surround the entire. Epineurium is not with entire nerve and blood vessels. Blood vessels nerve like दुईटैलाई separate गर्ने चाहिँ covered गर्ने चाहिँ हाम्रो epineurium हो, that is outside, okay. Perineurium means around the epineurium is all, and perineurium is like fascicles of nerve fibers. Nerve लाई मात्रै cover गर्ने भनेको perineurium हो. अनि endoneurium भनेको thin supportive connective tissue that encircles supports individual myelinated nerve fiber, okay. Individual myelinated nerve fiber लाई गर्ने चाहिँ endoneurium. Endoneurium को सबै जति endoneurium छ त्यसलाई cover गर्ने भने चाहिँ perineurium. Perineurium र blood vessel cover गर्ने चाहिँ endoneurium. So reaction chromatolysis is a reaction of neuron cell body to axon injury. Can reflex increased protein synthesis in efforts to repair the damaged axon. So round cell swelling and displacement of nucleus to the periphery, dispersion of initial substance to the cytoplasm. So valentilization is disintegration of the axon and myelin cell distal to the site of axonal injury with macrophage and removing debris. Proximal to the injury, the axon retracts and the cell body sprouts new protein that grow towards the neuron for potential reinnervation, serves as a preparation for axonal regeneration and functional recovery. So we have neurotransmitters, so many neurotransmitters, like the neurotransmitter called the acetylcholine, that is present in the basal nucleus of myot in the forebrain, okay. So it is decreased in the cases of Alzheimer's disease and Huntington's disease, okay. Alzheimer's and Huntington's has decreased acetylcholine in the forebrain, and Parkinsonism, the acetylcholine gets increased, okay. So next we have the dopamine, that is the ventral tegmentum and substantia nigra in the midbrain. So dopamine is with the midbrain, D for dopamine and midbrain. So the disease where the dopamine increases are the schizophrenia and Huntington's disease. The dopamine increase, whereas the dopamine is decreased in the depression and the Parkinsonism, okay. So dopamine is decreased in the depression and Parkinsonism, whereas increased in schizophrenia and Huntington's disease. So GABA is nucleus accumbens, which is present in the basal ganglia. So decreased in the Huntington's disease and the anxiety. GABA is decreased in the Huntington's disease and the anxiety. So we have norepinephrine, that is present in locus ceruleus pons, okay. So it is increase in anxiety and decrease in depression. Norepinephrine is decreased in depression, whereas in anxiety norepinephrine is increased. So next is the serotonin, okay. So serotonin is in rapid nucleus in the brainstem. So it is decreased in 3 diseases like anxiety, depression and Parkinsonism. Serotonin is decreased in the anxiety, depression and Parkinsonism. So what are the things that is we have to know is the acetylcholine and the dopamine has the reverse action, like in acetylcholine increase in Parkinsonism, decrease in Huntington's, whereas dopamine is increased in Huntington's and decrease in Parkinsonism, okay. So meninges will be like the dura matter, arachidoid matter we have from the neural crest cells, okay, and pia matter is also from the neural crest cells, okay. So what you need to know is the CSF flow in the sorapinous space between the arachidoid and the pia. Epidural space is potential space between the dura mater and the skull vertebrae column containing the fat and the blood vessels. Site of blood collection is with the middle meningeal artery injury. So next we have the blood-brain barrier, which is the tight junction between non-fasciated capillary endothelium, basement membrane and astrocytes. Glucose and amyloid cross slowly by carrier-mediated transport mechanism. Non-polar lipid-soluble substance cross rapidly by diffusion. Okay, so prevent circulating blood substance from bacteria drugs reaching the CNS. We have the subventricular organ with the fenestrated capillaries, no blood-brain barrier allow molecules in the area to affected brain function. Area posterior, vomiting after chemotherapy. Organum vasculosum, lamina terminalis, osmoreceptor or neurosecretory products to enter the circulation, neurophysis, ADH infection and neoplasm destroyed the endothelial cell tight junction and vasogenic edema. Hyperosmolar agents like mannitol can disrupt the blood-brain barrier and increase permeability of medication. So the vomiting centers coordinated by the nucleus tractus solitarius in the medulla, which receive information from the chemoreceptor trigger zone CT cell located in the area posterior in the fourth ventricle, GI tract by the vagus nerve, vestibular system and the CNS. CTZ and adjuvant vomiting centers nuclei receives input from five major muscarinic and dopaminic, histaminic, serotonin, and neurokinin. Pyosti D2 NK1 antagonist used to treat chemotherapy-induced vomiting. H1N1 antagonist treat motion sickness. H1 antagonist treat hyperemesis gravidarum. So now we'll be talking about the sleep physiology. Sleep cycle is regulated by the circadian rhythm, which is driven by suprachiasmatic nucleus of the hypothalamus. Circadian rhythm controls the nocturnal release of ACTH, prolactin, melatonin, norepinephrine, SCN. Norepinephrine release, pineal gland, increase melatonin. SCN is regulated by environment, light, two stress, rapid eye movement, and non-REM. Alcohol, benzodiazepines, and barbiturates assist with decreased REM sleep and N3 sleep. Alcohol, and norepinephrine also decrease REM sleep. So alcohol, benzodiazepines, and barbiturates decrease the REM sleep and N3 sleep, whereas norepinephrine only decrease the REM sleep. Benzodiazepines are useful for night terrors and sleepwalking by decreasing the N3 and the REM sleep. So benzodiazepines functions by decreasing the night terrors by decreasing the N3 and REM sleep. So when we are awake, eye open, which is alert and active mental condition, we have the beta with high frequency and low amplitude. Okay, and then when we are eye closed is alpha wave. Like when we are awake, eye open is beta wave, high frequency and low amplitude. When we are like awake but eye closed is alpha wave. And when you talk about the non-REM sleep, we have N1, N2, N3. N1 is 5% light sleep having the theta wave. N2 45% deep sleep when brucellosis, grindal occurs, spindle, sleep grindal and potassium efflux complex. And N3 is 25% deep non-REM sleep, slow wave sleep, sleepwalking, night terrors, bedwetting. So we flee in N3. So sleepमा वाक गर्छ अनि डराउँछ अनि मुद्दिन्छ पिसाब बेडमा. We have the delta wave, low frequency and high amplitude. Deepest sleep stage is the N3 stage. Okay. So next is the REM sleep, loss of motor tone, increased when oxygen use, variable pulse, BP, increased ACH. REM is when dreaming, nightmares, and penile clitoris turbulence occurs. May serve as memory processing function. Extraocular movements due to activity of PPRF, paramedian pontine reticular formation, conjugate gaze center occurs every 90 minutes and duration increase throughout the night. Okay. Change in the elderly is decreased REM, decreased N3, increased sleep latency, and increased early awakening. So change in elderly is decreased REM sleep, decreased N3, increased sleep latency. Okay. There is increased early awakening. Change in depression is this is the only one thing where the REM is increasing. Okay, that is in the depression. So increased REM sleep time, decreased REM latency, decreased N3, repeated night terrors, awakening, early morning awakening, terminal insomnia. So in depression everything goes down except the increased REM sleep time. REM को sleep time बढ़नु र REM को latency बढ़नु only in depression. Okay, change in narcolepsy is decreased REM latency. Okay, same. So at night bats drink blood. Is the mnemonic. So that D for beta, then alpha, then theta, then S for sleep spindle, then delta, and then beta. So bats drink blood. So bats drink blood is the mnemonic for eye awake, eye open, eye closed, then stage 1 to 3, then REM. And these bats drink blood. Bats drink blood. So now next we have the hypothalamus. So now we'll be talking about some of the left anatomy and physiology of the neuro and the drugs. So hypothalamus is the maintain homeostasis by regulating the thirst and water balance, controlling adenohypophysis and neurohypophysis, releases the hormones in the hypothalamus and regulates the hunger, autonomic function, temperature, arousal, or that is 10 hats. So hypothalamus controls the thirst and water balance, adenohypophysis, the neurohypophysis, the hunger, autonomic nervous system, temperature, sexual activity. Inputs are areas are not protected by blood-brain barrier. Okay, and OVLT is the sense change in osmolarity. Okay, and the area posterior found in the dorsal medulla responds to emetic. So just remember our K1 formula, that is the lateral nucleus, that is for hunger, destruction leads to anorexia, failure to thrive, stimulated by ghrelin and inhibited by the leptin. So the next we have the ventromedial nucleus, which is like for the safety, satiety, and destruction leads to craniopharyngioma by craniopharyngioma, and there is satiety gone and hyperphagia stimulated by leptin. Okay, so the lateral thalamus is a hunger, so hunger by ghrelin, that is in the stomach, and the satiety is by leptin, that is in the adipose tissue. Okay, ventricular injury makes you very musky. Lateral injury makes you lean. Lateral injury makes you lean, whereas the ventromedial makes you very musky, fat. Okay, so lateral for lean, medial for very massive. Very medial, very massive. Okay, anterior nucleus for cooling and parasympathetic. Posterior nucleus for heating and sympathetic. Suprachiasmatic for circadian rhythm. Supraoptic and paraventricular nucleus for synthesize ADH and oxytocin. Okay, ADH and oxytocin are carried by neurophysis down axons to posterior pituitary, where the hormones are stored and released. Preoptic nucleus for thermoregulation, sexual behavior, release GnRH. Failure of GnRH producing neurons to migrate from olfactory pits, also known as Kalaman syndrome. So now we have the nucleus of thalamus, major relay of all the sensory information except olfaction. So we have ventral posterolateral nucleus, that is the spinal thalamic and dorsal column, medial lemniscus. Sense are the vibration, pain, pressure, proprioception, light touch. Primary somatosensory cortex, parietal lobe. So ventro-posteromedial nucleus is trigeminal and gustatory pathway, face, sensation and taste. Okay, so primary somatosensory cortex, parietal lobe. We have the lateral geniculate nucleus and the medial geniculate. So lateral geniculate is associated with the cranial of two, optic chiasma and optic tract. Okay, and there is a vision and primary visual cortex is the destination, and for light. Medial, L for lateral, L for light, M for medial, M for music. So medial geniculated nucleus from medial forms the music, superior olivary and inferior colliculus of tegmentum. Next we have the ventral, anterior and lateral nucleus, which is the basal ganglia and cerebellum, which is the motor cortex and frontal lobe. Ventral sternates lobes to move. So motor cortex, ventral, antero, lateral nucleus from the basal ganglia and the cerebellum have the input. Okay, so the input are from ventro-posterolateral nucleus, the input from the spinothalamic and dorsal column and medial lemniscus. Ventro-posteromedial we have trigeminal and gustatory pathway input. Lateral geniculate nucleus we have the input from cranial nerve to optic chiasma and optic tract. Medial geniculate nucleus we have the input from superior olive and inferior colliculus of tegmentum. Ventro, antero and lateral nucleus is basal ganglia and cerebellum gives the input. So now we'll be talking about the limbic system, collection of the neural structure involved in emotion, long-term memory, okay, olfaction, medial behavior modification, ANS function, consists of hippocampus, okay, and that is the red arrow, okay, and amygdala, mammillary bodies, and thalamic nuclei, cingulate gyrus, okay, and entorhinal cortex. So consists of hippocampus, amygdala, mammillary body, entorothalamic nucleus, cingulate gyrus, entorhinal cortex, responsible for feeding, fleeing, fighting, feeling, and sex. Now we have the dopaminergic pathway, commonly altered by the drug antipsychotics, movement disorders by Parkinsonism, and so antipsychotics and Parkinsonism alters these pathways. So mesocortical is like decreased activity, negative symptoms, anesthesia, apathy, and lack of spontaneity. So antipsychotic has limited effect. So mesolimbic is like increased activity, positive symptoms like delusion, hallucination. Okay, primary therapeutic target of antipsychotic drug, decreased positive symptoms. Nigrostriatal is decreased activity, nigrostriatal symptoms, dystonia, akathisia, Parkinsonism, tardive dyskinesia. Major dopaminergic pathway in brain, significantly affected by movement disorder and psychotic drugs. Juvenile infantile is decreased activity, increased prolactin, decreased libido, sexual dysfunction, galactorrhea, and gynecomastia in males. So we have the cerebellum, modulates movements, aids in coordination and balance. So ipsilateral, there is unconscious proprioception, information by inferior cerebral peduncle from spinal cord. So ipsilateral unconscious proprioception information by inferior cerebral peduncle from spinal cord. You have the deep nuclei from lateral to medial, that is dentate, emboliform, globus and fastigial. From lateral to medial, dentate, emboliform, globus and fastigial. So lateral lesion affects the voluntary movement of the extremities, lateral structures. When injured, propensity to fall towards the injured ipsilateral side. Medial nucleus, we have the vermis, fastigial nucleus, floccular nodular load. So that are based in truncal ataxia, wide-based cerebral gait, nystagmus, head tilting. Cerebral results in ipsilateral motor deficit affecting the axial and the proximal limb musculature. So test finger nose test, gait, heel to shin test in this diadokinesia. Don't eat greasy food is the mnemoniform, dental emboliform, globus and fastigial. So this, when you talk about the cerebral input, it is from the contralateral cortex to medial cerebral peduncle, and that goes input to the brain. So next is the proprioception information from the spinal cord go to the inferior cerebral peduncle. Okay, from the cortex goes to the medial cerebral, and from the spinal cord goes to the inferior cerebral peduncle. From the inner ear, from the vestibular nuclei, it goes to the what you call the floccular nodular lobe. Okay. So the things that you have to remember is that the lateral cerebellum, okay, gets the input from the middle cerebral peduncle from the cortex, and inferior cerebral peduncle from the spinal cord laterally. So next is we are having this input goes inside, okay, and then there is the, for the output there is the deep nuclei from lateral to medial. We have already studied what is there. So cerebral cortex by Purkinje cells get the information and supply to the deep nucleus, and deep nucleus then give the superior cerebral peduncle, and then gives the contralateral cortex the information. Similarly, the inner ear vestibular nuclei gives the information to the floccular nodular, and vestibular nuclei then does the balance and the eye movement. Okay, and the floccular nodular lobe is associated with the nystagmus and vertigo due to vestibular nucleus complex. Okay, and the vermis is having a medial descending system, intermediate lobe is lateral descending system, motor exudation ipsilateral. Okay, so coordinates bilateral corticospinal. That's it. So the next is we are having the basal ganglia. So basal ganglia is important in voluntary movements and disgusting posture. Receive cortical input, provide negative feedback to cortex. Okay, stratum is putamen plus caudate. Lentiform nucleus is putamen plus clavus pallidus. Okay, so D1 is direct pathway, indirect is D2. So direct excitatory pathway, SCN inputs to the stratum by nigrostriatal dopaminergic pathway, release GABA, which inhibits GABA release from the GPI, disinhibiting the thalamus by the GPI motion, increases motion. So indirect pathway, SCN inputs to the stratum by the nigrostriatal dopaminergic pathway. Okay, release GABA that inhibits STN by GPE inhibition. STN stimulates GPI to release the thalamus, decrease motion. So dopamine binds to D1, stimulate the excitatory pathway, or and to D2 in dopamine binds to D1, stimulate the excitatory pathway, and to D2 inhibiting the inhibitory pathway and increases the motion. Okay, we can see the diagram, very high diagram. So at first the when you see the soft cortex, there is the lateral ventricle up. Just below the lateral ventricle, attached with the lateral ventricle are the two caudate nucleus. Okay, and there is below these things, the lateral ventricle and small caudate nucleus. On the lateral side of the lateral ventricle, we have the what you call the hypothalamus, and just below the thalamus there is the hypothalamus, which is very small. Okay, so from the thalamus, when you go laterally, there is the internal capsule. Then we have the globus pallidus internus and externus. Okay, and then we have the putamen. Then after that, more laterally is the insula. Okay, and just below the thalamus there is the hypothalamus, and just by the side of the thalamus or behind, when you like the hypothalamus draws the hand, it touches the subthalamic nucleus and substantia nigra. Okay, and the mammillary body is just below the hypothalamus. Okay, so thalamus, hypothalamus, mammillary body. Once again, there is first the lateral ventricle, then the caudate, then just below the thalamus, then there is globus pallidus and internus, externus just laterally. More laterally is the putamen, and more laterally is the insula. Just below the thalamus there is the third ventricle is in between the two thalamus, okay, and lateral ventricle goes down. So now we'll be talking about the cerebral cortex region, okay. So cerebral cortex region is like we are having the primary motor cortex, okay, and primary sensory cortex. Then there is a primary between the primary motor cortex and the primary sensory cortex. Primary sensory cortex is posteriorly, okay. Primary motor cortex is anteriorly and divided by central sulcus. We have the frontal lobe for the attention, plan, organize, and decision making. Just above the frontal lobe, there is a frontal eye field, control horizontal eye movement, okay. And we have the Broca's areas in the frontal lobe, okay. So that is and we have the frontal below, whereas the temporal superior is the Wernicke area. Just in front of the Wernicke area we have the primary motor cortex, okay, and mastoidea cells infection to brain from the temporal lobe can occur. So now next we'll be talking about the cerebral perfusion relies on the tight autoregulation, primarily driven by PCO2. PO2 also modulates perfusion in severe hypoxia, also relies on pressure gradient between the mean arterial pressure and intracranial pressure, decreased blood pressure or ICP, decreased cerebral perfusion pressure, Cushing reflex is triad of hypertension, bradycardia, and respiratory depression in response to increased ICP. So therapeutic hyperventilation is decreased POCO2, vasoconstriction, decreased cerebral blood flow, decreased ICP, may be used to treat acute cerebral edema secondary to stroke, unresponsive to other interventions. CPP is equals to MAP minus ICP, that is central CPP. Okay, cerebral perfusion pressure is equals to MAP minus ICP. Okay, if CP is zero, there is no cerebral perfusion branded. Hypoxia increases CPP only if PO2 is less than 50%. CPP is directly proportional to PCO2 until PCO2 is greater than 90%. So we can see in the graph the PO2 with the cerebral blood flow and the pressure. PCO2 is red line, which is decreasing from up to down, whereas the PCO2 from the PCO2 PO2 from 100 it is going down to the 50 and it's getting saturated, whereas the from 25 PCO2 getting rising to the level of near to the 100, and the MAP is from 25 to 75 nearby maintenance. Okay. So now we'll be talking about the homunculus. When we talk about the medial, from medial side, we have the medial cerebral lobe, we have the leg, then the leg of our, then leg is connected to the hand. Okay, leg is connected to the hand, and the face is like in the just downwards. Okay, so this is the motor homunculus, and the sensory homunculus is also the same. So tropic representation of motor sensory area in the cerebral cortex, distorted appearance is due to cerebral body region during the right sleep phenomenon, and thus having increased cortical presentations. So anterocerebral artery is the medial lobe, so that is determines the leg, that's way, and the medial cerebral artery determines the hand and the face, and the PCA determines the occipital lobe. So there is something called watershed area zone. Cortical bone border zones occurs between the anterior and posterior medial cerebral arteries and posterior and medial cerebral arteries. Internal border zone occurs between the superficial and deep vascular territory of the medial cerebral arteries. Common location for brain metastasis includes common location for brain metastasis is the watershed area. Infarction due to severe hypoperfusion, ACA, MCA watershed area. Proximal upper and lower limb weakness, man in barrel syndrome. So PC and MCA watershed area, high zone of visual disturbance. So now we have the circle of Willis. When we have the pica, we have the ASA that is doing the medial medullary syndrome and lateral medullary syndrome by pica. Okay, which is a branch of vertebral artery. Then these two vertebral arteries go down from basilar artery. From the basilar artery arises the ICA, which is doing the lateral pontine system. Then basilar artery goes up, and it above the basilar artery it gives superior cerebral artery. Then it goes off and it gives the basilar artery gives the PCA, posterior cerebral artery, which is the branch of basilar artery. So now the internal carotid artery gives the branch of MCA, and then the MCA gives the posterior communicating branch. It gives the anterior choroidal branch, and then it goes to a branch, and we have the anterior cerebral artery, okay, which is also coming from the the internal carotid artery. Okay, and the middle cerebral artery is Thus we can see the okay, and the internal carotid artery giving the branch of everything, like middle cerebral artery, the anterocerebral artery, the posterior communicating artery, and there is optic chiasma. So at the there is the brachiocephalic trunk, aorta, and the subclavian. So you see a common carotid artery, and there is external carotid artery. Internal carotid artery goes inside the brain, and we have the ACA, MCA, and PC comes from the vertebral artery only. Okay, vertebral artery gives the posterior communicating artery. Okay, and basilar artery gives the posterior PCA. Okay, posterior communicating artery. So now we're talking about the dural venous sinuses, that is large venous channels that runs through the periosteum and the meningeal layer of the dura mater, drain blood from the cerebral vermis, receive CSF from arachnoid granulation, empty into the internal jugular vein. Venous sinus thrombosis present with the significant increased ICP, headache, seizure, papilledema, focal neurological deficit may lead to venous thrombosis associated with the hypochondrial stress like pregnancy, OCP, and factor V Leiden. So we can see here there is a cavernous sinus which is related in draining to the spinopalatal sinus, and then to there is occipital subophthalmic vein which is also draining. Okay, and that is they are connected. All these are connected to superior sagittal sinus. That is the main location of CSF return by arachnoid granulation. Superior sagittal sinus is the main location for CSF return by arachnoid granulation, and now we have the confluences of the sinuses. Okay, here the things that are coming are superior sagittal sinuses, and the great cerebral vein of Galen connect to the straight sinus and then to the confluence of the sinuses, and then there is the occipital sinuses. The confluence of sinuses now then go to occipital from the occipital sinuses, and transverse sinus also reaches the confluence of sinuses, and then here from here it all goes to the transverse sinus, and then to the sigmoid sinus, jugular vein, and inferior jugular vein. Okay, now we have the ventricular system. The lateral ventricles, from the lateral ventricle, third ventricle by right and left, interventricular foramen of Monro, third to fourth ventricle by cerebral aqueduct or sylvius. Okay, lateral to third ventricle is by right and left, interventricular foramen of Monro. Third to fourth ventricle is by cerebral aqueduct of sylvius, and fourth ventricle to subarachnoid is foramen lusca, alpha lateral, foramen megandae, alpha medial. CSF made of choroid plexus located in lateral and fourth ventricle, travel to subarachnoid space by foramen of lusca and megandae, reabsorbed by arachnoid granulation, and then drain into dural venous sinuses. So force above the pons, that is 1 to 3 4, 4 exists the pons, that is 5 to 8, and 4 in the medulla are 9 to 12, and medial are 3 4 6 and 12, factor of 12 except 1 and 2. So we can see in the diagram, this is very high diagram. So optic bulb we can see, olfactory tract. Okay, infundibulum we have the mammillary body, and we can see the third nerve that is arising from the midbrain, and the fourth is just lateral of the midbrain, and now we'll be talking from 5 to 8, that is the pons. So 5 is just lateral to the pons, 6th is medially, 7th is a little bit lateral from 6th, and then is 8, 5, 6, 5 is laterally, then 6, then 7, and then 8 are there. Now after 8 we're looking at the medulla. So medulla matching hamro, medially is the 12th nucleus, and rest all 3 are lateral. Okay, so you need to remember it that way. So when we talk about the cerebellum removed, okay, so we have the third ventricle, thalamus, both sides, and in the midbrain we have the thalamus, and there is the pineal body between the thalamus, and there is the between the thalamus there is the superior colliculus and the inferior colliculus, and then as you go down there is the superior cerebral pedangle, middle cerebral pedangle, and inferior cerebral pedangle. Pineal gland, melatonin secretions or cadmic rhythm, superior colliculus driven eye movement to stimuli or objects interest, inferior colliculi to the auditory nerve. So superior colliculus, inferior colliculus which are attached to the thalamus are related to this, and your eye are above the ears, so superior colliculus visual is above, the inferior colliculus is auditory. So similarly the cranial nuclei located in the tegmentum portion of the brainstem between the dorsal and the ventral portion. Okay, Okay, so midbrain is having the nuclei of the same thing is being repeated. Okay, so midbrain is having the nuclei of 3 and 4, pons nuclei from 5 to 8, medulla from 9 to 12, and spinal cord nucleus of 10 of 11. So spinal cord is containing the nucleus of 10 of 11. Okay, and the lateral nucleus is like sensory alar plate, and the medial nucleus is medial nucleus चाहिँ हाम्रो मोटर हुन्छ हैन, lateral nucleus चाहिँ sensory plate हुन्छ. Sulcus limitans. So vagal nucleus, we have the nucleus tractus solitarius as for sensory. So visual sensory information, taste, baroreceptor, gut distension may play a role in vomiting. Cranial 5, 7, 9 and 10 is carrying by it. Okay, this nucleus ambiguous motor innervation of pharynx, larynx, upper esophagus. Here also 9, 10 and 11. So first it was the sensory from 7, 9, 10, and motor common is with the sensory like is 9 and 10, and 11 cranial portion. Dorsal motor nucleus is sends autonomic parasympathetic fibers to heart, lungs, upper GI. Okay, so now we'll be talking about the cribriform plate is there. Okay, so in middle cranial fossa we have optic canal, we have superior orbital fissure. So from the superior orbital fissure goes the cranial 3, 4 and 6. Okay, and the foramen rotundum V2, and the superior orbital fissure also there is V1. So 3, 4, 5 को V1, 6 को 6. Foramen rotundum V2, foramen ovale V3, foramen spinosum, middle meningeal artery. So now we have inferior auditory matters, cranial of 7 and 8, jugular foramen 9, 10, 11 and jugular vein, hypoglossal nerve 12, and foramen magnum has brainstem, spinal root of cranial of 11, vertebral arteries, spinal root of 11th nerve, brainstem, and vertebral arteries. Okay, so foramen lacerum goes from here, meningeal branch of ascending pharyngeal artery and emissary vein. Okay, so next is we know this everything. Okay, so olfactory is for like smell, we know that. Only cranial without thalamic relative cortex. Okay, it has no thalamic relative cortex. So optic nerve is a side, oculomotor nerve, eye movement, SR, IR, MR and IO, pupillary, Edinger, sphincter, pupillary constriction. Okay, sphincter pupillae, erector, pretegmentum nuclei, Edinburgh vespal nuclei, scleroreceptor accommodation, eyelid opening and levator purpurary, trochlear for eye movement, trigeminal mastication, facial sensation, ophthalmic maxillary mandibular, somatosensory from 2/3 of the tongue and dampens of the loud noise by tensor tympani, abducens eye movement, facial movement test at 2/3 of tongue, quadra tympani, lacrimation, salivation, submandibular and sublingual glands in a cranial of 7, eye closing orbicular iris, auditory, volume, modulation, spasticity, vestibulocochlear, hearing and balance, glossopharyngeal, taste and sensation from posterior 1/3 of the tongue, swallowing, salivation, parotid, monitoring carotid body and sinus, chemo and baroreceptor, elevation of pharynx and larynx, stylopharyngeus. Vagus nerve is taste from supraglottic region, swallowing, soft palate elevation, middle lobula, talking, cough reflex, parasympathetic to thoracoabdominal viscera, monitoring aortic arch, chemo and baroreceptor. Accessory is head turning, shoulder shrug, SCM and trapezius, and hypoglossal is the tongue movement. So cranial reflex, corneal by B1 ophthalmic, nasociliary branch, whereas bilateral different from bilateral 7th temporal branch of orbicularis oris. Cough is 10, coming and going both 10, 10 going from also from phrenic and spinal nerve, gag 9 and 10. Jaw reflex is V3, and sensory from muscle sphincter from masseter, and V3 motor masseter. Lacrimation is V1. Loss of reflex does not preclude emotional tear, and efferent is by 7. Lacrimation B1 and B7. Pupillary 2 and 3. Okay, so now we're talking about the muscles of mastications, that is masseter, temporalis, and the medial pterygoid. Lateral pterygoid protrudes the jaw and are innervated by trigeminal of B3. So spinal nerve, 31 pairs of spinal nerve, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. C1 and 2 C5 exist above the corresponding vertebrae. C3 exists above C3 vertebrae, cervical vertebrae. C8 spine nerve exits below C7 and above T1. So all nerve root exists below, L2 exists below the second number vertebrae. So in adult, spinal cord ends at the lower border of L1 and L2. Subarachnoid space, which contains the CSF, extends to the lower border of S2. Lumbar puncture is usually performed between L3, L4, L4, L5, level of cauda equina. Goal of the lumbar puncture is to obtain sample of CSF without damaging the spinal cord. To keep the cord alive, keep the spinal cord below L3 and L3. Needle passes through skin, fascia, and fat. Supraspinatus ligament, interspinous ligament, and ligamentum flavum. So three things are there, like supraspinous ligament, interspinous ligament, and ligamentum flavum. Then arises the epidural space. Epidural anesthesia needle stop here. So then after that we have the dura, arachnoid, and subarachnoid. Okay. So spinal cord, the leg is are the lateral, the lateral corticospinal and spinal thalamic. Thoracic spinal cord section. Dorsal column organized as you are with hands at the side along. Dorsal columns are arranged as you are with the hands at the side, arms outside, leg inside. Dorsal column is arranged like hand outside and leg inside. Okay. So lateral corticospinal, we can see we have the intermediate intermedial lateral column, that is sympathetic T1 to L to L3. Dorsal column we have, posterior horn we have. Okay, we have the anterior horn, anterior and posterior horn, all the mix. We have the lateral corticospinal and anteroid commissure. So when you talk about the fasciculus gracilis, which is medial, which lower leg and leg. Fasciculus spinatus is lateral, upper body arm. So we have the ascending the lateral spinothalamic tract and anterior spinothalamic tract. Similarly, we have the descending lateral corticospinal tract and the anterocorticospinal tract. Similarly, we have the spinal tract anatomy and function, ascending tract, synapse, and then process. Okay, so we have the dorsal column, that is the pressure, vibration, fine touch, proprioception. First order neuron is sensory nerve ending, bypass pseudo unipolar cells. Cord in the dorsal column, enter ganglia, enter the spinal cord, essence ipsilateral in dorsal column. First synapse is the synapse nucleus gracilis and cuneatus, ipsilateral medulla. The second order is decussation in medulla, essence contralateral in the medial lemniscus. And the synapse plus projection is from the 2BPL. So spinothalamic tract, lateral pain and temperature, anterior touch, crude touch and pressure. So sensory nerve ending A delta and C fibers, bypass pseudo unipolar cells, body in the dorsal root ganglia, enter spinal cord. Synapse 1 is ipsilateral perimeter. Synapse cord, decussation, second order neuron is decussation is spinal cord as the enteroid commissure, essence contralateral to the BPL. So now we have lateral corticospinal tract, volumetric control of the lateral limbs, upper motor primary cortex descends related through the posterior limb of the internal capsule and the cerebral pedangles. Most fibers decussate at the caudal medulla, pyramidal decussation and descends contralaterally. Primary synapse is the synapse of the anterior horn spinal cord. Second is the lower motor region leaves the spinal cord and the muscle fibers. So now we have the clinical reflexes. Achilles reflexes S1 and S2, bulky by Su. Patellar reflex L2, L4, that is kicks the dome. And spinal and brachiocephaly is C5, C6. Tricep is C6, C7, and C8. Ribastic reflex is L1 and L2. Testicles move. Ankle wing reflex is S3, S2. Vincus glariole reflex grading. 0 absent, 1 hypoactive, 2 vanicose normal, 3 vanica hyperactive, 4 vanicoplanus. So primitive reflex, CNS reflexes that are present in healthy infants but are absent in neurological intact adults normally disappear within the first year of life. These primitive reflexes are inhibited by mature developing frontal lobe. These are emerging in adult following the frontal lobe region, loss of inhibition of this reflex. We have Morose reflex hang on for life reflex. Abduct and extends arm when started and then drawback. Rooting reflex is movement of the head towards the side if cheek or mouth is stroked. Suckling reflex, sucking response when mouth, roof of the mouth is touched. Palmar reflex is curling of the finger if palm is stroked. Plantar reflex is dorsiflexion of the last toe and fanning of the other toes with plantar stimulation. Babsky sign presence of all these reflex in adult which signify upper motor lesion. Gallant reflex is stroking along the one side of the spine, while newborn is in ventral suspension, face downward, causing lateral flexion of the lower body towards stimulated side. C2 is posterior half of the skull. C3 is high turtleneck sheath. Diaphragm and gallbladder pain refer to the right shoulder by phrenic nerve. C3, C4 keeps the diaphragm alive. C4 is the lower polar sheath. C6 is the thumb. Sign of the left hand looks like 6. T4 at the nipple. T7 at the xiphoid process. T10 at the umbilicus. L1 is the inguinal ligament. L4 includes the kneecap downward. S2, S3 as per sensation of the penile and the anal zone. S2, S3 keeps the penis on the floor. Okay, thank you. Next we have the auditory, anatomical and physiology. So now we'll be talking about the ear and eye. So internuclear ophthalmoplegia is the medial long nucleus fasciculus, a pair of the interconnect sixth and the third nerve nuclei coordinate both eye to move into the same horizontal direction. Highly myelinated must communicate quickly to eye move at the same level. Lesion may be unilateral or bilateral. Later classic is seen in the multiple sclerosis stroke. Lesion in MLF inter-ophthalmic nucleoplasia INO or conjugate horizontal gaze palsy. Lack of the communication such that C and cranial nerve 6 nucleate activates ipsilateral lateral rectus and contralateral third nerve nucleus does not stimulate medial rectus to contract. Abducting eye displays or nystagmus. C cranial nerve 6 overfires to stimulate the cranial nerve 3. Okay. Third nerve problem is there. So ipsilateral adduction cannot be done. So convergence is normal. MLF, when looking eye left nucleus of 6th fires while contract the left rectus and stimulate the contralateral right nucleus of 3rd by right MLF to contract the right medial rectus. Direct term right INO, left INO refers to the eye that is unable to abduct. INO is ipsilateral adduction failure and nystagmus contralateral. So cavernous sinus thrombosis is collection of the cavernous sinus on either side of the pituitary. Blood from the eye and superficial cortex, cavernous sinus, intrajugular vein. Third, fourth, V1, V2 and 6 post ganglionic sympathetic pupillary fibers enters the root to the orbit all through the cavernous sinus. Cavernous sinus portion which are carotid artery is also here. Cavernous sinus syndrome is with the variable ophthalmoplegia. Third nerve, sixth nerve, decreased cortical sensation, horn syndrome. Occasional decreased maxillary sensation to secondary pituitary mass effect, cavernous sinus fistula or cavernous sinus thrombus related to infection. So similarly, when the right optic right eye is gone, so there is right anopia, monocular vision loss. When there is second, that is the optic tract, when it is optic nerve is gone, so it's palpebral, hemianopia, pituitary lesion and chiasma. When the third is gone, optic tract, so there is left homunus hemianopia. So when the fourth, the temporal lobe, the mirror lobe is gone, so that is the right temporal lesion, MCA, that is the left upper quadranopia. When the fifth dorsal optic radiation or ipsilateral load within the parietal lobe gone, so there is left lower quadranopia, and PCA gone, left hemianopia with macular sparing, that is right occipital lobe. Central scotoma, there is macular degeneration. Mirror lobe, lower retina, lower air around inferior horn of lateral ventricles. Dorsal optic radiation, superior retina makes short path by internal capsule. So there is third nerve damage. Third nerve has both motor central and parasympathetic peri component. Common cause includes ischemia, pupil sparing, motor fibers affect more than parasympathetic fibers, uncal herniation, coma, post comic aneurysm, sudden onset headache. We have the cavernous sinus thrombosis, that is the protosis, involvement of cranial 5, 4, V1, V2 and V6, mid brain stroke, that is contralateral hemianopia. We have motor output to extraocular muscle affects the primary vascular disease, diabetes mellitus, glucose or sorbitol decrease due to decreased diffusion of oxygen nutrients due to inner fibers, more compact vasculature than sites on the outer of the nerve, syntosis and outer nodal palsy. Parasympathetic output fibers on the periphery are first affected by compression, that is posterior commuting aneurysm or uncal herniation. Sign diminished or absent pupillary right reflex, blown out pupil open with blowout gaze. 6th nerve damage, Pupil is high in the affected eye. Characterized head tilt to contralateral non-affected side to compensate for lack of the intorsion in the affected eye. Can't see the floor with fourth nerve damage. Very difficult going through downstairs and reading. So motor is middle central. The parasympathetic is peripheral. Okay, so cranial nerve 6 is affect the unable to abduct and is displayed medially in primary position gaze. Okay, fourth nerve is the eyes up, so it can see the floor. Floor and so cranial nerve 6 innervates the lateral rectus, 4 innervates the superior oblique, 3 innervates the rest. Oblique go opposite, left, SO, and IO tested when patient looking upright. IO tested intraocular IO, IO tested looking up. So blown out fracture is orbital floor fracture, usually caused by direct trauma to eyeball or infraorbital rim. Increased risk of higher muscle or increased orbital fat entrapment may lead to infraorbital nerve injury. So we have the Horner syndrome, that is sympathemimetic degeneration of the face, ptosis, slight dropping of eyelid, superior tarsal, anhidrosis, absence of sweating and flushing of the affected side, meiosis, affected lesion along the sympathetic line, primary neuro is pontine hemorrhage, lateral medullary syndrome, spinal cord lesion, FOP1, Brown-Sequard syndrome, late stage syringomelia. Second neuron is stellate ganglion compression by Pankos tumor. Third neuron is cavity dissection painful and anhidrosis usually absent. Okay. So the hypothalamus is starts internal carotid. So first order neuron synapse in the lateral on, then it goes to second order neuron, then it goes up to the C2, where there is the third order neuron. It goes to external carotid artery. So there is it goes to the sweat glands, goes to the pupillary dilator, then it has branches to sweat gland, long ciliary nerve, ophthalmic division of trigeminal nerve. Okay. So there is Marcus pupil, also called relative afferent pupillary defect, when the light shines into a normal eye, constrict of the lateral direct reflex and contralateral eye constrictor reflex is observed. When the light is swung to the affected eye, both pupil dilate instead of constrict due to the impaired conduction of light seen along the injured optic nerve, with the optic neuritis, multiple sclerosis, optic neuropathies like giant arthritis. So next is the mydriasis, which is dilation and sympathetic. His first order neuron is hypothalamus to ciliopspinal center of bulge, that is C8 to T2. Second order exists at T1 to superior cervical ganglion, travels along the cervical chain near the long applications of Levin vessels. Third order neuron is plexus along the internal carotid through the cavernous sinus center orbits as a long ciliary nerve to dilator. Sympathetic fibers also innervates smooth muscles of eyelid, inner minor retractors and sweat glands of forehead and face. Long ciliary nerve makes the pupil diameter long. So pupillary light reflex, light is the retina sends signals by two pretectal nuclei, dashed line in image, and midbrain that activates the middle onychophorans nucleus. Pupil constricts bilaterally, diet and constant reflux, result in illumination of one, results in bilateral pupillary constriction. So meiosis is constriction, parasympathetic, forehead is onychophorans nucleus to ciliary ganglion by third nerve. Second order is short ciliary nerve to spinal pupilla. Short ciliary nerve shortens the pupil, whereas long ciliary nerve pupil dilates the pupil. Next is leukocoria, loss of whitening of the red lip, important cause in child with retinoblastoma, congenital cataract, papilledema, optic disc swelling, usually violated due to increased ICP, secondary to mass effect, enlarged blind spot and elevated optic disc with blurred margin. Retinitis pigmentosa is inherited progressive dystrophy of the retinal pigments, epithelium and photoreceptors, may be associated with the orbitary hypotonemia or defining myopia. Night blindness, peripheral vision loss, fundoscopy shows triad of optic disc pallor, retinal vessels attenuation and retinal pigmentation with bone spike shaped deposit. You have central retina artery occlusion, that is acute painless mononuclear vision loss, retina occluded with attenuated vessels and stereo spot, and fovea central of macula, evaluate for embolic strike, carotid artery atherosclerosis, cardiac irritation, patent foramen over. Retinal detachment is a separation of the neurosensory layer of the retina, photoreceptor layer with the rods and cones, often outermost pigmented epithelium, normally shaded. Excessive light support retina, degeneration of photoreceptor vision loss may secondary to retinal break, diabetes traction, inflammatory fusion, which lies in fundoscopy or creep of retinal tissue challenge, change in vascular effusion, break often more common in patients with high myopia, high head trauma, often preceded by posterior vitreal detachment, hots and flutters, eventually monocular loss of vision by shortened draw down surgical emergency. So retinal vein occlusion is blockage of the central or the branch retinal vein due to compression from nearby arterial atherosclerosis, retinal detachment, and venous engorgement, blood and thunder appearance, edema in affected area. Hypertensive retinopathy is chronic uncontrolled hypertension, endothelial disruption, fibrinoid necrosis, and retinal detachment, flame-shaped retinal hemorrhage, and arteriovenous leaking, microaneurysm, and macular star exudate, retinal color, cotton spot, presence of papilledema requires immediate lowering of BP, associated with the increased risk of stroke in CAD and kidney disease. We have diabetic retinopathy, retinal detachment due to the chronic hyperglycemia, 2 stages, non-proliferative damage, capillaries, leak blood, lipid and fluid seen in the retina, hemorrhage, macular degeneration, treatment blood sugar control, proliferative, chronic hyper results in new blood vessel formation with resultant traction on retina, retinal detachment, treatment with anti-VEGF injection, peripheral retinal photocoagulation and surgery. Next we have the age-related macular degeneration, degeneration of the macule, central area of retina cause distortion of straight lines, metamorphosia, eventually loss of the central vision like scotoma, primate non-oxidative with the 80% deposition of alveolar material dozens in the between the branch membrane and retinal pigment epithelium with gradual decrease in pigment, prevent progressive with multivitamins and antioxidant supplements, weight exudate 10 to 15%, rapid loss of vision due to the bleeding secondary to bronchoidal neovascularization, treat with anti-VEGF, vascular endothelial growth factors, injection, bevacizumab and ranibizumab. So we have the uveitis, that is inflammation of the uvea, specialized name based on the location within the affected eye, anterior uveitis, iritis, posterior uveitis, choroiditis, and retinitis may be hypopyon, accumulation of pus in anterior chamber or conjunctival redness associated with the systemic inflammation disorder, sarcoidosis, rheumatoid arthritis, juvenile idiopathic arthritis, HLA-B27 associated conditions. Next we have the glaucoma, that is optic disc atrophy with the characteristic cupping versus thinning of the outer rim of optic nerve head, usually with elevated IOP and progressive peripheral vision loss. If untreated, treatment includes pharmaceutical surgery lowering of IOP, open angle glaucoma, increased stress in older people, black people, and patients with the family history condition. Painless, more common in US. Common cause, primary cause is unclear. Secondary, blockade trabecular MSP from WBC, uveitis, RVC from vitreous hemorrhage and retinal elements like retinal detachment, close or narrow angle glaucoma, primary enlargement of the anterior omoidal lens and central iris, pupil margin, obstruction of the normal aqueous flow through the pupil, fluid built up inside the iris and pushing the iris against the cornea, impaired flow through the trabecular mesmer, secondary hypoxia from retinal disease, diabetes mellitus, when occlusion induces the vascular progression in the iris and contracts the angle, chronic closure of asymptomatic with damage to optic nerve and peripheral vision, acute closure to ophthalmic emergency, increase IB, pushes iris forward, acute closure abruptly, very painful, red eye, sudden vision loss, halos around eye lights, frontal headache, sweet and middle, dilated pupil, nausea, vomiting, mydriatic acid contraindicated, hearts in hurry with halos, headache and dilated pupil. Normal, this is the cupping we can see. Okay. So open angle and angle closure. Yeah, and angle closure, glaucoma. So uveitis, inflammation of the uvea, name is specific based on location within the affected disease. Anterior uveitis, iritis, posterior uveitis, choroiditis or retinitis may have hypopyon, accumulation of pus in the anterior chamber or conjunctival redness associated with the systemic inflammation disorder, sarcoidosis, idiopathic arthritis, juvenile idiopathic arthritis, HLA-B27 conditions. So next is the cataract. So trabecular outflow 90% drainage through the trabecular mesmer, canal of Schliemann, epithelia vasculature, increase M3 agonists like carbachol and pilocarpine, vascular outflow, drainage with the uvea and sclera with increased prostaglandin agonist, lateral prostaglandin and production, decreased by beta blocker, timolol, alpha 2 agonist by grimidine and carbonic antagonist acetazolamide. Okay, we have the cataract. There is a painless one bilateral opacification can result in a glare, decreased vision, especially at night, loss of the red reflex. Acute risk factor includes age, tobacco smoking, alcohol overuse, excessive sunlight, prolonged cortical sweat, diabetes mellitus, trauma, infection. Congenital risk factor includes classical galactasia, galactokinase deficiency, trisomy 13, 18, 21, TORCH infection like rubella, Marfan, Alpert, myotonic dystrophy, or neurofibromatosis 2. This IQ is related impaired accommodation, focus on the near object, primarily due to decreased lens elasticity, change in the lens curvature, and decreased strength of the ciliary muscle. Patient often have reading glass magnification. So the normal conjunctivitis is inflammation of the conjunctiva radius, allergic itchy eye, bilaterally. Bacterial pus treated with antibiotic, viral most common often adenovirus, spares mucous discharge and swollen peri-auricular mode, increased lacrimation, self-losing hyperopia, also called farsightedness, eye too short for refractive error of corneal lens, eye so correct with the convex lens. Okay, convex lens लाई करेक्ट गर्नेछ पहिला हाइपरोपिया थियो हैन कन्भेक्सले गर्ने अनि मायोपिया भनेको चाहिँ नियर साइडनेस त्यसलाई चाहिँ हामीले कन्सिडर आई लुक टु फर रिफ्र्याक्टिभ अफ द कर्निया power of the cornea lens light focused in front of the retina stigmatism abnormal curvature of the cornea different refractory power at different age contact with cylindrical lens. Next we have the vertigo, that is sensation of this spinning while actually stationary, subtype of dizziness but distinct from lightheadedness. Peripheral vertigo more common than central vertigo. So peripheral vertigo due to inner ear pathology such as semicircular canal debris, benign paroxysmal positional vertigo BPV, vestibular nerve infection, Meniere's disease, triad with the sensory neural hearing loss, vertigo, tinnitus, endolymphatic hydrops, increased endolymph within the inner canal, treatment antihistaminic, anticholinergic, antiemetic, losartide, Meniere's disease, epilepsy. We have the central vertigo, brain stem or the cerebral lesion, stroke affecting the vestibular nuclei, demyelinating disease or post foci tumor, finding directional or purely vertical nystagmus, skew deviation, vertical misalignment of the lens, diplopia, dysmetria, focal neurological findings. So vertigo is sensation of the spinning while actually stationary, subtype of the dysrhythmus but distinct from lightheadedness. Peripheral vertigo more common than central vertigo. So in a Rini test is normal bone conduction greater than air conduction which is conducting, but Weber test is simply like when it is normal no localization when it is conducted, so localized to affected ear, okay. And when it is like sensory neury, it is localized to unaffected ear. So similarly we have the noise induced hearing loss, that is damage to stereocilia in the organ of body, loss of high frequency hard hearing first, sudden extremely loud noise can produce hearing loss due to tympanic membrane rupture. So presbycusis is related progressive bilateral symmetrical hearing loss, often due to high frequencies, leads to destruction of the hair cells at cochlear base, preserved following lower frequency hearing at apex. So we have the outer ear, which is the visible portion of the ear, includes auditory canal and tympanic membrane, transport sound by vibration of tympanic membrane. Middle ear is the ear filled space with the three bones called ossicles, malleus, incussus, ossicles to conduct and amplify sound from tympanic membrane to inner ear, where the inner ear snail-shaped fluid-filled cochlea contains basilar membrane that vibrates secondary to sound wave. Vibration transducted by specialized hair cells, auditory nerve signaling, brainstem. Each frequency leads to vibration at specific localization on the basilar membrane called tonotopy. Low frequency heard at the apex near trauma, wide based and flexible. High frequency heard just at the cochlea, that is thin and rigid. And that's it with the so now we'll be talking about the drugs of the central nervous system. So glaucoma decreases IOP by amount of aqueous production. Humor inhibits synthesis and secretion of increased drainage. So bad is the humor may not be politically correct. So BAD bad, PC is the mnemonic. B for beta blocker, A for alpha agonist, D for diuretics, C is prostaglandins, and C is cholinergics. So beta blockers are timolol, betaxolol, and carvedilol decrease aqueous humor production. So decreasing the aqueous humor production is the bad decreases the aqueous humor production. You need to remember. Okay, that is the synthesis. So timolol, bitalol, and cartilol decrease aqueous humor, no pupillary or visual changes with beta blockers. So alpha agonists are epinephrine, okay, brimonidine, that is alpha 2, epinephrine is alpha 1, okay, and this both decreases the aqueous humor synthesis, okay. Epinephrine does by vasoconstriction, okay, and mydriasis alpha 1 do not use in closed angle glaucoma. So alpha 1 agonist is like the epinephrine not used in closed angle glaucoma. Okay, blurry vision, ocular hyperemia. Side effects are blurry vision, ocular hyperemia, foreign body sensation, ocular allergy, and reaction, ocular pruritus. Diuretics, we have the acetazolamide. BAD, bad D for D is acetazolamide, decrease aqueous humor synthesis. Okay, by inhibition of carbonic anhydrase, no pupillary or visual change. So now we have PC. So P is bematoprost and latanoprost, that is prostaglandin F2 alpha. So now what is they are going to do? The PC is going to increase the outflow of the aqueous humor. Okay, 3 decreases the production, 2 increases the outflow. Okay, so bematoprost and latanoprost increase outflow of aqueous humor by decrease resistance of flow through uvascular pathway. So darken color of the iris and blowing and eyelashes growth. So bematoprost does what? Eyelashes growth. Now we have the cholinomimetic, that is M3. So direct pilocarpine, carbachol, and indirect is physostigmina. M3 receptor, cholinomimetics are M3. So direct pilocarpine and carbachol, indirect is physostigmine. Okay, so it increases the outflow of the aqueous humor by contraction of the ciliary muscle and opening of the trabecular mesua. Use pilocarpine in acute angle glaucoma, closure glaucoma, very effective at opening mesua in canal of Schliemann. And the side effects are myiasis, contraction of the pupillary sphincter muscles, and cyclospasm, that is contraction of the ciliary muscles. So next we have the tramadol, that is very weak opioid agonist, also inhibits the reuptake of norepinephrine and serotonin used in the chronic pain, similar to opioid, decrease seizure threshold and serotonin syndrome. So tramadol is a slight opioid agonist and serotonin and norepinephrine reuptake inhibitor. It is used for stubborn pain but can lower seizure threshold and may cause serotonin syndrome. So next we have the opioids. Okay, so in the mixed agonist and antagonist opioid analgesics is like pentazocine. Pentazocine is kappa opioid receptor agonist and mu opioid receptor weak antagonist or partial agonist. So analgesic for moderate to severe pain, can cause opioid withdrawal symptoms if patient is also taking full opioid agonist due to competition of opioid receptors. So next we have the butorphanol, that is the kappa opioid receptor agonist and mu opioid receptor partial agonist. Okay, pentazocine was mu opioid receptor weak antagonist or partial agonist, whereas it is mu opioid receptor butorphanol is added with mu opioid receptor partial agonist. So used in the severe pain, migraine can be used, cause less respiratory depression than full opioid agonist. Used with full opioid agonist can prescribe withdrawal, not easily reversed with naloxone. So next is the opioid analgesics. Acts as an agonist at opioid receptor. Mu is equals to beta endorphin. Delta is equals to enkephalins, and gamma is equals to kappa is equals to dysmorphin. Mu is equals to beta endorphin, delta is equals to enkephalin, and kappa is dysmorphin. To modulate sympathetic transmission, close presynaptic sodium channels, open postsynaptic potassium channels, decrease synaptic transmission, increase release of ACH or norepinephrine, 5-HT, glutamate or substance P. So opiates efficacy, full agonist are morphine, heroin, meperidine, which is long acting, methadone, codeine, which is a prodrug, and activated by CYP2D6, and fentanyl. Partial agonist is buprenorphine. Mixed agonist antagonists are nalbuphine, pentazocine, and butorphanol. Antagonists are naloxone, naltrexone, and methyl natrioxane. So clinical is moderate to severe refractory pain, diarrhea, loperamide, and diarrhea. It also can be diphennoxylate. acute pulmonary edema. Maintenance program for opioid use disorder includes methadone, buprenorphine plus naloxone. In neonatal abstinence syndrome, use methadone or morphine. So, adverse effect includes nausea, vomiting, pruritus like histamine release, opioid use disorder, respiratory depression, constipation, sphincter of aorta spasm, meiosis, except meperidine, leads to mydriasis, additive CNS depression with other drugs. Tolerance does not develop due to meiosis and constipation. And treatment toxicity with naloxone, competitive opioid receptor antagonist, and prevent relapse with increased naltrexone once detoxified. So, next is spasmolytic and antispasmodic. So baclofen is GABA B receptor agonist in the spinal cord. Okay, and it used in the muscle spasticity, dystonia, muscle and multiple sclerosis. Okay, cyclobenzaprine is acts by within the CNS, mainly at the brainstem, used for muscle spasticity. Cyclobenzene acts within the CNS, mainly at brainstem, muscle spasticity. Note: centrally acting structure related to CA may cause anticholinergic side effects. Okay, and sedation. So next we have dantrolene, prevent release of calcium from sarcoplasmic reticulum skeleton by inhibiting the iodine receptor, used in the malignant hypothermia, toxicity of inhaled anesthesia and succinylcholine, and neuroleptic syndrome, toxicity of antipsychotic drugs, act directly on muscles. We have tizanidine, which is alpha 2 agonist and acts centrally, muscle spasticity, muscles multiple sclerosis. Tizanidine, okay, which is alpha 2 agonist. So, muscle spasticity, multiple sclerosis, ALS, and cerebral palsy. So, next we have the neuromuscular blockade drugs, muscles paralysis in surgery or mechanical ventilation, selective for NM nicotinic receptor at neuromuscular junction, but not as autonomic NM receptor. So, depolarizing neuromuscular blocking drugs, succinylcholine, strong ACH receptor agonist, produce sustained depolarization and prevent muscle contraction. Reversal of blockade, phase 1, prolonged depolarization, no antidote, block potential by cholinesterase inhibitors. Phase 2, we have repolarization but blocked ACH receptor at available but desensitized, may reverse with cholinesterase inhibitor. Complication of depolarizing includes hypercalcemia, hyperkalemia, malignant hyperthermia, increased of prolonged muscle paralysis in patient with pseudocholinesterase deficiency. So, non-depolarizing neuromuscular blocking agents includes atacurium, pancurium, robicurium, dubicurium, vericurium, competitive ACH antagonist. Okay, so reversal of the blockade is sumadex or cholinesterase inhibitor like neostigmine, adrophonium. Okay, so anti-cholinesterase like atropine, glycopyrrolate are given with cholinesterase inhibitor to prevent the muscarinic effect like bradycardia. So we have the local anesthesia. So among the local anesthesia, we have the ester, procaine, tetracaine, benzocaine, and chlorprocaine. In the amides, we have lignocaine, mepivacaine, bupivacaine, dropivacaine, and all these amides have 2I in name. Okay. So mechanism is blocked neurotransmission by binding to voltage-gated sodium channel or inner surface of the channel along the nerve fiber, most effective in rapidly firing neurons. 3-degree amine local anesthesia penetrates membrane in nonsense form, then binds to ion channel as charged form. Can be given with vasoconstriction, usually epinephrine, to enhance the blocking duration of action by decreased systemic absorption. In ineffective acid tissue, alkaline anesthesia are changed and cannot penetrate muscle effectively, needs more anesthesia. Okay, so clinical use in minor surgeries, procedure, spinal anesthesia if allergic to ester. So adverse effects include CNS excitation, severe cardiovascular toxicity, bupivacaine, hypertension, hypotension, arrhythmias with cocaine, and methemoglobinemia with the benzocaine and pilocaine. Okay, so next is the intravenous anesthesia, which is the thiopentine, facilitates GABA, like barbiturates. Anesthesia indication, short surgical procedure, decreased cerebral blood flow, high lipid solubility, effect permitted by rapid redistribution into flat tissue and fats. So midazolam facilitates GABA. Okay, to facilitate thiopentine and midazolam facilitates GABA. Thiopentine is facilitating GABA A, that is like barbiturates, whereas midazolam is facilitating GABA A like benzodiazepines. Okay, benzodiazepines, so midazolam, thiopentane is a barbiturates. So the midazolam is doing what? Procedural sedation, example endoscopy, anesthesia induction, can cause severe postoperative respiratory depression, decreased BPM, and retrograde amnesia. Propofol is potential GABA E, also rapid anesthesia and induction, short procedure, and ICU sedation may cause respiratory depression, decreases the BP. We have ketamine and NMDA receptor antagonist, dissociative anesthesia and sympathomimetics, increased cerebral blood flow, emergence reaction possible with distortion, hallucination, and vivid dreams. Now we have inhaled anesthesia like desflurane, halothane, influrane, isoflurane, sevoflurane, methoxyflurane, and 2. Mechanism unknown. Effect myocardial depression, respiratory depression, postoperative nausea, vomiting, increased cerebral blood flow, ICP, decreased cerebral metabolic demands. So inhaled anesthesia include adverse effects include hepatotoxicity with the halothane, nephrotoxicity with the methoxyflurane, and proconversion with influrane, and EP leptogenic. An expansion of the trapped gas in the body cavity is N2O. So malignant hyperthermia is rare life-threatening condition in which inhaled anesthesia or succinyl choline induce severe muscle contraction and hypothermia. Substitutable if often inherited as autosomal dominant with variable penetration. Mutation in the ryanodine receptor RYR1 cause increased calcium release from sarcoplasmic reticulum. Treatment is dantrolene, ryanodine receptor antagonist. So now next we have the anesthesia general principle. CNS drug must be a lipid soluble cross blood-brain barrier or actively transported. Drug with decreased solubility in blood equals to rapid reduction and recovery time. Drug with increased solubility in lipids increased potency. MAG is minimum orbital concentration of inhaled anesthesia required to prevent 50% of subject from moving in response to noxious stimuli. Skin incision potency is equals to 1 by MAG. Example includes nitrous N2O has a decreased blood and lipid solubility and thus fast induction and low potency. Halothane has increased lipid and blood solubility and thus high potency and low induction. So next we have the neurodegenerative disease therapy, which is like in the Alzheimer's we have the donepezil ACHE inhibitors, that is donepezil, rivastigmine, and galantamine. First line treatment, adverse effect nausea, dizziness, insomnia, contraindicated with cardiac conduction abnormalities. Okay, so we have memantidine, also given in the Alzheimer's, that is NMDA receptor antagonist, help prevent excitotoxicity mediated by calcium, used for moderate to advanced dementia, advanced effects in dizziness, confusion, and hallucination. Amyotrophic lateral sclerosis, that is glazole, mechanism decreased neural glutamate excitotoxicity. Notes is increased survival and treat low grade disease with glazole. So we have Huntington's disease, that is tetrabenazine, inhibits vascular monoamine transport VMAT, decreased dopamine vesicles transport and release, may be used for Huntington's, chorea, and tardive dyskinesia. Next we have the drugs that are used for like Parkinsonism. So the most effective treatment are non-incretin dopamine agonists, which are usually started in young patients, levodopa with carbidopa, which is usually started in older patients. Brain stimulation of the STN or GPI may be helpful in advanced DP. Dopamine agonist non-incretin preferred, that is pramipexole or ropinizole. Toxicity cause nausea, impulse control disorders like gambling, postural hypotension, hallucination, and confusion, whereas incretin means the bromocriptine rarely cause due to toxicity. Increased dopamine availability by amantadine, increased dopamine release, and decreased dopamine reuptake. Toxicity, peripheral edema, libido, reticularis, and ataxia. Increased L-dopa availability. Agent prevents peripheral L-dopa degradation. Increased L-dopa entering CNS. Increased central L-dopa available for conversion to dopa. Levodopa, L-dopa / carbidopa. Carbidopa blocks peripheral conversion of L-dopa to dopamine by inhibiting the dopa decarboxylase. Also reduced side of peripheral L-dopa conversion into dopamine. Okay, entacapone and tolpacapone prevents the peripheral L-dopa degradation to 3-O-MD by inhibiting the COMT used in conjunction with levodopa. So prevent dopamine breakdown by agents act centrally like post blood-brain barrier to inhibit breakdown of dopa. So selaginine and resalagine blocks the conversion of dopa into dopac by selectively inhibiting the MAOS-B, whereas tolcapone cross blood-brain barrier and block conversion of dopa to 3 methoxytyramine 3-MT in brain by inhibiting the central COMT. Corb access cholinergic activity. Benzotropine trihexyphenidyl, that is antimuscarinic, improves tremor, rigidity, but little effect on bradykinesia in Parkinsonisms. So next we have carbidopa, levodopa. Increased dopa in the brain, unlike dopamine, L-dopa can cross the blood-brain barrier and is converted to by dopa decarboxylase in the CNS to dopamine. Carbidopa, a peripheral dopa decarboxylase inhibitor, is given with L-dopa to increase the viability of L-dopa in the brain and to limit peripheral side effects. Carbidopa, levodopa, clinical use in the Parkinsonism disease and in a nausea, hallucination, postural adverse effects of levodopa carbidopa includes nausea, hallucination, postural hypotension with progressive disease. L-dopa can lead to an on-and-off phenomenon with improved mobility during on periods, then impaired motor function during off periods when the patient responds poorly to L-dopa on medication thereof. Selagilin and reselagin. So selective inhibits the mouse B, increased dopamine ability. Selagin selective inhibits mouse B and is more common found in the brain than in the periphery. So adjuvant agent L-dopa in treatment of Parkinson's disease may enhance the adverse effects of L-dopa. So the drugs that are used in migraine includes the triptans, that is sumatriptan, 5-HT1B 1-day agonist, inhibit trigeminal nerve activation and prevent vasoactive peptide release, induces vasoconstrictions. So clinical use in acute migraine and cluster headache attack. So adverse effect of sumatriptan include coronary vasospasm, contraindicated with CAD or vasospastic angina, mild paresthesia, serotonin syndrome in combination with 5-HT agonist. Next we have the insomnia drugs, which is non-benzodiazepine hypnotics, which includes zolpidem, zalipolone, isopiclone, acts by benzodiazepine one subtype of GABA receptors. We have ataxia, headache, confusion, can cause modest day activity after psychomotor depression and few amnestic effects. Older setting hypnotics. Non-benzodiazepine hypnotics includes these benzodiazepines puts you to sleep, short duration due to rapid metabolism by liver enzyme, effect reversed by flumazenil, decreased dependency risk, decreased sleep cycle disturbance versus benzodiazepines and hypnotics. We have suboxazepam, that is orexin hypnotic receptor antagonist, CNS depression, somnolence, headache. Have used adverse effect include CNS depression, somnolence, headache, abnormal sleep disturbance. So contraindicate narcolepsy combination with the strong CYP3A inhibitors, not recommended in patients with liver disease. Limited risk of dependency. We have rameldione, that is melatonin receptor agonist, binds MT1 and M2 in suprachiasmatic nucleus. So adverse influence includes dizziness, nausea, fatigue, and headache. Okay, so next we have the benzodiazepines. So this is the diazepam, lorazepam, diazepam, okay, triazolam, temazepam, oxazepam, midazolam, and chlordiazoperoxide and olanzapine. So facilitates GABA1 action by increasing frequency of GABA channel opening. Increased frequency, decreased REM sleep, must have long half-life and active metabolite. Alprazolam, triazolam, oxazepam, midazolam are short acting with higher addictive potentials. So clinical use in anxiety, panic disorders, spasticity, status epilepticus, lorazepam, diazepam, midazolam, eclampsia, detoxification. So alcohol withdrawal, DTS, long-acting chlordiazepines and diazepams are preferred. Night terrors, sleepwalking, general anesthesia, hypnotics, lorazepam, olanzapam, temazepam can be used for those with liver disease with lot to minimize first class. So adverse medication dependency, addictive CNS depression effect with alcohol, barbiturates, all binds with the GABA1 receptor, risk of respiratory depression and coma than with the barbiturate. Treat overdose with clomazepine, competitive antagonist with GABA benzodiazepine receptor, can precipitate seizure by acting acute benzodiazepine withdrawal. So next we have the barbiturates, phenobarbital, barbitol, thiopentan, and secobarbital. So facilitates GABA1 action by increasing duration of the chlorine channel opening and thus decrease neural fighting, and increases barbiturates increase duration, whereas benzodiazepine increase frequency. So barbiturates sedative for anxiety, seizure, insomnia, induction of anesthesia like thiopentane. So side effects of barbiturates includes respiratory, cardiovascular depression, CNS depression, dependency drug interaction. Overdose treatment is supportive and instead respiration and maintenance PP, contraindicated in barbiturates are contraindicated in porphyria. So now we'll be talking about the antiplatelet drugs. So the drugs that are sodium channel blockade are carbamazepine, phenytoin, lamotrigine, phenytoin, topiramide, and valproic acid. Sodium channel blockade, carbamazepine, phenytoin, lamotrigine, phenytoin, topiramide, and valproic acid. Okay, so that are sodium calcium channel inhibitors are ethosuximide and gabapentin. On levetiracetam is SVA2A receptor blocker. So that is during the release. So GABA. Okay, so we have the GABA A receptor for chlorine to block the depolarization. So potentiate the GABA A receptor in the postsynaptic inhibits the depolarization with the help of chlorine. So that is done by benzodiazepines, topiramide, and phenobarbital. GABA receptor agonist is benzodiazepines, topiramide, and phenobarbital. So similarly, GABA reuptake inhibitor is tiagabine. Okay. So similarly, we have the succinyl semi-aldehyde. GABA converted into succinic semi-aldehyde from GABA transaminase, and this GABA transaminase is inhibited by valproic acid and vigabatrin. Okay. So now we'll be talking some of the benzodiazepines. Okay, increases the GABA A action, sedative, tolerance. Side effects include sedation, tolerance, dependency, respiratory depression. Also used for eclampsia, seizure. First line is magnesium sulfate. So next is carbamazepine. So it blocks the sodium channel. And side effects of carbamazepine includes SADH, SJS, aplastic anemia, or granulocytosis, which are very asked. And a part of them, diplopia, ataxia, liver toxicity, teratogenicity, cleft lip and palate, spina bifida, induction of cytochrome P450. First line trigeminal neuralgia. So ethosuximide blocks thalamic T-type calcium channels. Side effect starts from E, so EFGHIG. So E for ethosuximide cause fatigue, G for GI disturbance, F for fatigue, H for headache, I for itching, and S for SJS. Sought to have silent absent seizure. So gabapentin is the one used for partial seizure. Okay, ethosuximide is used for absent seizure. Carbamazepine for partial focal seizure. So partial focal seizure, we have so many partial focal seizure. Okay, and okay, so now we have the gabapentin primarily inhibits high voltage calcium channels as GABA analog. Sedative, ataxia side effect, also used for peripheral neuropathy and postherpetic neuralgia. So next we have the lamotrigine, which is block the voltage gated sodium channel, inhibit the release of glutamate. Side effect includes SJS, must be titrated slowly, hemophagocytic lymphocytosis, black box warning. We have levetiracetam, that is SBA receptor blocking, may modulate GABA and glutamate release, inhibit voltage gated calcium channels. So levetiracetam neuropsychiatric symptoms, personality change, fatigue, drowsiness, and headache. We have phenobarbital, increased GABA action, sedation, tolerance, dependency, induction of cytochrome P450, cardiorespiratory depression. First line in unit is phenobarbital. So we have next is phenytoin and phosphenitoin. It blocks the sodium channel, zero order kinetics. Phenytoin mnemonic is P450 induction. Next P is pseudo lymphoma. As for hirsutism, E for enlarged gum, as for nystagmus, yellow brown skin, teratogenicity, osteopenia, inhibited folate absorption, neuropathy. So rare. Okay. So topiramide is block sodium channel, increase GABA action. We have sedation, slow cognitive, kidney stone, skinny, sight threatened, speech difficulty, also used for migraine prophylaxis. We have valproic acid, increase sodium channel inactivation, increase GABA concentration by inhibiting the GABA transferase. So valproate has side effects includes vomiting, alopecia, liver damage. Valproate को valproate नहीं हो. So B for vomiting, A for alopecia, L for liver damage, pancreatitis, P450 inhibition, rash, obesity for weight gain, tremor, tetragenicity, okay, epigastric pain. Also used for myoclonic seizure. Alpha is used for myoclonic seizure, bipolar disorder, migraine prophylaxis. We have bigabatrin, it increased GABA, universal GABA transaminase inhibitor, permanent visual loss, black bus warning, visual loss with GABA transaminase inhibitors.